Okay. Well, good morning, good evening, good night, wherever you are in which part of the world. This is the London Global Cancer Week session about the Breast Cancer Care Quality Index, a tool that has been developed by a network of experts from different parts of the world in order to improve cancer care, breast cancer care, and facilitate the exchange of information and data. What is the BCCQI and why it is important, why it is needed? This index is a unified framework that translates broad guidance from existing initiatives into more practical applicable metrics. It is an expert endorsed and designed to drive actionable systematic healthcare transformation and improve the quality of breast cancer care for all patients. Today, more than 80% of the world population has diagnoses and treatments that are not following the best standard of care or are not following the best strategies or rules for cancer care. While significant advances have been made in breast cancer care, much remains to be accomplished to improve outcomes. In the past, resource stratified and clinical practice guidelines which target broad audiences exist, absolutely. Yet implementation is inconsistent and limited across countries, with many nations being regrettably off track to meet the target of the WHO Global Breast Cancer Initiative to reduce breast cancer mortality by 2.5 annually. And only some high-income countries showing sustained consecutive annual reductions. So countries, health systems require an overarching framework with elements to enhance breast cancer care and promote equitable, evidence-based care and this is mainly important, improve the outcomes for all patients by supporting the creation of context-specific roadmaps aligned with the local needs and resources, opportunities, and challenges. Continued progress requires a paradigm shift to address current and future challenges and to align with rapid advancement in health technologies. This shift calls for broadening the scope of ownership to include a more diverse and comprehensive group of stakeholders. We need to broaden the number and characteristic of the stakeholder. Such collaboration must be inclusive and foster shared responsibility, enabling an holistic approach to address the complexities of breast cancer care. So, following the agenda of this meeting, we have now the presentation of Professor Benjamin Anderson. Professor Anderson is one of the global leaders in breast cancer. I am sure that for more than 20 years, he was leading diverse initiatives, starting with the Breast Health Initiative in Seattle in around 2006, I think, and introducing the concept of stratified guidelines. And that, at that time, that was really a shift of the paradigm because the guidelines were not only for doctors, the guidelines were recommendations for policymakers and for healthcare systems. Trying to improve the situation. So after a lot of collaborations with many international and national organizations, including WHO recently, Dr. Anderson, I am sure, will give us a clear and fundamental explanation of why and what do we need to do to improve the index? Dr. Anderson, you have the floor, please.
Well, thank you very much for the opportunity, Dr. Kazap. I'd like to congratulate the group on this. Thanks to SLACOM. I would particularly like to thank the outstanding work of our colleagues at Policy Wisdom that you'll be hearing from today. What I'd like to do is build the case for the BCCQI, the Breast Cancer Care Quality Index, within the context of the World Health Organization Global Breast Cancer Initiative Framework. It's important for us to recognize in the beginning that there is no single organization that can fix breast cancer globally. There is no single metric or outcome that we can identify. But what we are doing is building together these opportunities for improving these outcomes. What I hope to do in the next 15 minutes is to share with you how the BCCQI relates to the WHO Global Breast Cancer Initiative framework. As Dr. Kazap said, the original basis for much of our work came from the Breast Health Global Initiative, BHGI, which held 6 global summits between 2002 and 2018. That was sponsored by Fred Hutchinson Cancer Research Center and Susan G. Komen for the Cure. And subsequently, our work after the launching of the WHO Global Breast Cancer Initiative framework was supported through a very special partnership between Amgen, AstraZeneca, BMS, and MSD, which supported these collaborations between WHO and City Cancer Challenge. For those that have seen presentations on GBCI, the overall objective, as Dr. Kazap had indicated, is to reduce breast cancer mortality by 2.5% per year. That would save 2.5 million lives over a 20-year period. The concept of the GBCI framework is to take what we learned between 1990 and the present time, in which breast cancer mortality, as you see in these graphs here, was reduced by 40%. And the question is, how do we translate what was learned predominantly in high-income countries to translate these outcomes to low and middle income countries that have not yet seen the benefit? And the approach that was adopted by GBCI and is mirrored in BCCQI are the 3 pillars: early detection, prompt diagnosis, and treatment to completion. This is a pathway that patients go through, and it's the pathway by which we can identify if the systems are working well or not. Early detection, in which patients present either with clinical findings like a lump or thickening in the breast, or because of screening programs, where screening is done for high-risk groups. The target is for at least 60% of patients with invasive cancer to be diagnosed at stage 1 or 2. So that's a threshold that GBCI had identified as being key. This also has been adopted by BCCQI, as we'll see in a minute. Prompt diagnosis is an essential area in which patients present with either symptoms or imaged findings, and they undergo a diagnostic process to determine who has cancer and who does not, and also what subtypes are available so that treatment can be planned. The goal is for cancers to be diagnosed within 2 months, 60 days, and that's because at 3 months we start to see a decline in breast cancer survival. So that gives us another key performance indicator. And the third key performance indicator for GBCI is multimodality treatment to completion without abandonment, the goal being at least 80% of patients to achieve this level. And it's very important to remember and to relay to ministries of health that equally important are supportive services, because it's the supportive services that help patients get through the processes. Again, it's important to recognize when we improve outcomes, It's not a single test. Early detection is not a test. Early detection is a process. Treatment is not a drug. Treatment is a set of treatments that are appropriate for a specific cancer as they were diagnosed. Now, how does this relate to the BCCQI indicators? And what I'd like to do is walk through with you how the quantitative indicators relate to the GBCI framework to show you that they are indeed measuring the same outcomes. So BCCQI has dimensions, as you'll see on the left side of the graph. Those dimensions align with the GBCI pillars: early detection, prompt diagnosis, and treatment to completion. And so those dimensions, those first three dimensions, already fit within the GBCI framework that WHO supports. The fourth dimension are strong and resilient healthcare systems. So these are overview metrics that look at the system overall and identify specific resources. So the BCCQI outcome metrics shown here in orange align with each of the GBCI key performance indicators. So BCCQI and GBCI directly align when we look at those outcome metrics. But knowing outcome metrics, knowing our mortality, knowing our distant outcomes, such as survival, that does not yet tell you where the gaps are. And so BCCQI goes into a deeper level in which process metrics are included, as you see here in blue. And those process metrics identify where to go within each pillar for a specific environment or situation. The fourth indicators are structural indicators that we need in order to assess, do we have those overall resources? But what the greatest strength of this process is, we identify critical system gaps. This is what ministries of health need to know, because that's where the resources need to be directed. Late stage presentation is one of the most common problems globally, where the majority of patients are presenting with stage 3 or stage 4 cancers. Here on this diagram, you can see the size of T2 and T3 lesions, which are so common in Africa and Latin America. The question of whether breast exam, clinical exam, can improve outcomes was a debate for some time, but we now know from India that actually when late stage presentation is common, clinical detection can improve mortality for breast cancer for women over the age of 50. So that key performance indicator for the early detection is embedded within the BCCQI dimensions, and in addition, process metrics help us identify the degree to which screening is happening. So again, a deeper dive into Pillar 1. WHO has been discussing the relative value of screening versus early diagnosis. This figure going back to 2017 when WHO first published it. It's essential to recognize that when we screen, we examine 1,000 women with mammographic screening, 150 of which will need a diagnostic workup to identify perhaps 10 cancers. So screening is very resource intensive. Early diagnosis, in which we find patients who have become symptomatic because of palpable lumps, that is a more efficient system. For every 10 women presenting with a palpable lump, 1 has cancer. That is a practical solution. We had debated for some years whether waiting until symptoms developed was too late. We now know from the Mumbai screening trial that in fact, when that late stage presentation is common, we can reduce mortality, at least for women 50 and above. And all of this emphasizes the critical value of staging our cancers. We need to know stage distribution. IARC looked at cancer stage distribution for countries globally. This is a set of countries that provide these examples. The purple and blue bars show stage 1 and 2, relatively speaking. And these staging study data would indicate that all of these countries are doing quite well. But it's important to recognize that when we don't stage all of the cancers, when we have a significant group of patients who are not staged, we don't know enough. So that in the example of Vietnam, while the stage distribution looked excellent, that was only for a small fraction of patients where the stage was known. So that message, both from GBCI and BCCQI, that message of staging and knowing stage distribution cannot be overemphasized. The second pillar, prompt diagnosis. We need to make a diagnosis within 2 months or 60 days in order to start treatment within 3 months. And as we talked about before, the GBCCQI goes into greater depth to identify where are all the diagnostic tools, not just cancer, yes, no, but also the tumor markers, ER, PR, HER2, neu, getting into that greater depth that was not part of the key performance indicators for GBCI. We have guidelines. And NCCN, as an example, has excellent guidelines about how to work up lumps. The purpose of showing you this graph is to indicate that, again, screening is not a test. Diagnosis is not a test. It is a process, and it depends on how the patient presents. These are straightforward, but must be recognized and implemented. And diagnostic tools such as ultrasound. While we talk about mammography for screening, ultrasound is the workhorse of breast diagnosis. It's how we distinguish cancers from cysts, from benign lesions. And again, those guidelines to walk us through this process are something that each Ministry of Health must consider as they identify their patterns. So, what's needed for a diagnostic facility? How do we decide if our diagnosis processes are adequate? We need accessible facilities. They need to be geographically accessible and they need to be financially accessible. We need the imaging, and this is much more than the equipment. Yes, we have to have adequate equipment, but without the trained staff that allow this, we will not see the processes moving forward. Again, speaking to how each of these services are processes, not individual tests. Pathology needs to be available. We need access and timeliness. And patient navigation is a theme that weaves throughout all of this work, both with our index and with GBCI, which WHO has since released a technical document summarizing needs for patient navigation, in which we assess integrity of the referral process, we measure timeliness, and we recognize this as a foundation for treatment, the third pillar of the GBCI framework. That framework of at least 80% of patients completing their multimodality treatment is that core concept reflected in the outcome metric of the third BCCQI dimension. And further, we have subdivided the indices into biological subtypes so we can identify which subsets of patients are having treatment that may or may not be complete. We know from the work of IARC that it is essential to recognize the high prevalence of incomplete treatment. In 5 sub-Saharan countries, we saw from IARC's work that of those that began treatment within 3 months, only half completed it. And that virtually guarantees that we will not see all of the benefits that are needed. Again, BCCQI measures these outcomes by biological subtype. We can project that by addressing the improved treatment, downstaging of disease, and improved access, those are the 3 key performance indicators, we can predict major outcome improvements as measured by survival. And so we do seem to be, by aligning GBCI and BCCQI, we are going to be able to measure those outcomes. We have talked about navigation. We have a tendency in our systems to think most about the most expensive services, and we think less about the organization that makes those systems functional. So, here, as one example, is a study out of Cali, Colombia, in which patient navigation was implemented. Our Colombian colleagues had recognized the difficulties of accessing patients, administrative delays slowing the process, limited communications, with measurable waiting times that were well beyond those that were needed. And what you can see in the graph on the right is how navigation can improve each of these areas. And so navigation becomes one of the most important tools, very affordable, very doable. The question is, how do we navigate through the stormy waters of breast cancer? So, in summary, the Breast Cancer Care Quality Index defines essential metrics framing the GBCI framework that was published in 2023. The GBCI framework provides this context-specific guidance to improve breast cancer outcomes for countries at all resource levels. We have context-specific guideline outcomes. The GBCI framework outlines those three pathways for the pillars of early detection, prompt diagnosis, and treatment to completion. The breast cancer index that we are talking about today mirrors those three pillars and furthermore goes to that next level, that next essential level of quantifying process metrics, patients going through the patient pathway. And with this, ministries of health and collaborators can identify the systematic gaps in patient care that are the hub of the delays that we see. We can anticipate using BCCQI within the context of GBCI that we can anticipate improved outcomes over the next years and decades. With that, I'd like to thank you again for the opportunity to present today.
Thank you. Thank you so much, Dr. Anderson, for this fantastic presentation that combines previous data with international data from WHO and puts into perspective the index. Thank you so much. And now we will move to the experience in a particular region of the world with Professor Emad Shash. He's a medical director of the breast cancer clinic at the National Cancer Institute of Cairo. And he's a world leader expert in breast cancer. As you know, one thing are documents and another thing is reality. So we will listen very carefully Dr. Shah's comments and information. Dr. Shah, you have the floor. Thank you very much.
Thank you, Dr. Kazab. It's really a pleasure to be here, and thanks for SLACOM for giving me the opportunity to be on this marvelous panel. Thanks, Dr. Anderson, for paving the way on how to do it, and for also policy wisdom and the team for making this happen. So actually, one important point is to get back into reality, as what has Professor Anderson had highlighted, and Professor Gazab also highlighted this. So from Egypt, a low middle income country, is it working? Is not working? What have been done? Professor Anderson had paved the way clearly, and why we need a BCCQI. Particularly, this is the point of interest, that we have more of new breast cancer cases, and there is the global inequality. There is inequitable incidence and mortality. high-income countries, and as well the patients from the low-middle-income country have higher mortality rates. Basically, one important point is that we need to look into people from low middle income countries and see that we have more of advanced stage diagnosis. And those of advanced stage diagnosis have actually added to it a fragmented healthcare system. And that's actually what the Global Breast Cancer Initiative brings into. The Global Breast Cancer Initiative with the three pillars that Dr. Anderson had mentioned, but it's a multi-sectorial approach, having integrated the approach, the service delivery to have the equity in healthcare. And basically, the BCCQI builds on the WHO Global Breast Cancer Initiative. The breast key dimensions, one important fact from these dimensions is to have a strong and resilient healthcare systems. And this is very important to have an operational roadmap that can be adopted through the different goals, targets, and indicators. And that's very important to prove this ahead. So basically, what we have done in Egypt at the national level is that we took what was in the Global Breast Cancer Initiative and put it in the presidential initiative that commenced in July 2019, trying to see that we have more of patients on advanced stage. So we basically did it a 4+4 workforce development, the infrastructure, the data system, and the global collaborations as well. And we have presented 2 years ago our initial data from our program, covering the whole Egyptian governorates, 27 governorates. And as mentioned, it is clearly a stepwise early detection, and that's what we like. It's moving from the screening to early detection, because in stage 3 or 2, you don't need to have mammography as a beginning, but you need to have experience. And we did this in a stratified way to have a first visit to the primary healthcare unit, and then patients who are, or population who are older than 35 years, to go for the clinical breast examination by healthcare professional, and as well, if there is an abnormality, to go to a tertiary care center. So at that time, 32 million population, 10, those are the 10 million who presented to the primary healthcare unit. We had 5 million ladies who presented to clinical breast examination. And you can see that what we have found, that 10 out of 100 women had abnormal finding. Clearly, this is a must to see that those who then move to the tertiary healthcare center, of those over 1,622,000 women presented to the tertiary. And what we have found clearly, that those who went to the biopsy, we come down to the 5,000 incident breast cancer. But then the quick wins that we have seen clearly a down staging, that more than 80% of those 5,000 ladies who were diagnosed with breast cancer have been diagnosed in stage 1 and 2. That sustainability is important, and this is very important to see that it is sustainable till today. We have more than 60 million visits, and today we have of more than 30,000 breast cancer patients diagnosed. So this is what we have done in the presidential initiative, and what we have seen, that we have more than 70% have been there. So we achieved the pillar 1 of the Global Breast Cancer Initiative. Again, the diagnosis is very important, and it is a mandatory step for all currently cases to be treated of multimodality and to go for MDT. So again, this is what payers like to hear, that with the payers, that more of those patients that you spend of £1 Egyptian, you have a gain of 1.38 Egyptian pound. So this is the ROI, and this is actually life savings and as well economically saving. On a tertiary cancer center level at the Breast Cancer Comprehensive Center, which is the biggest comprehensive cancer center dedicated for the treatment of breast cancer, it's very important as well to go from only treatment to value-based model based on focus patient outcomes, cost efficiency, provider accountability, and integrated care. And this is very important because we all know that the journey has a lot of barriers. And a lot of barriers is not only in the suspicion, but diagnosis. And speaking to this, and that's what highlighted by Professor Anderson, is the treatment execution and the follow-up. So to do this, you need to have clear pathways, you need to have navigation in process, measuring the success and tracking it. So that's basically what we have done based on the Global Breast Cancer Initiative to try to see what is the hypothesis to have a decrease in the time from they present to our center to the start of therapy. And that's actually by having in place patient navigators since April 2022, and to have this for the efficient delivery. We have published this earlier at the Journal of Cancer Education that we decreased the time from 40 days to 29 days, but as well, this is accompanied by a more stringent system by having higher approval rates for the reimbursement and dropping from 30% to 8.6%. And that was actually combined with the satisfaction. So 87% of our patients feels that the presence of navigation improved their journey out in our hospital. We went through, and that was published last month, that we think of the WHO essential list, and one of them is the anti-HER2 therapy. And actually, we did this to see if there is a streaming of the journey. And actually, what we have seen that we measured from the registration to the MDT, to the MDT from the MOH, and the MOH for the approval, and the for approval the surgery. And what we have seen that we have 24 days saved, 11.6 days have been saved from the therapy to therapy intervention, and as well that we have a higher PCR rates of 69%. So basically, this is not all, and health promotion is very important. And we know that cancer is a complex disease, a lot of psychological needs. And we did a survey back in 2021, and what we have seen that 60% of patients and caregivers either have the fact of none or semi messages that have been seen. And they are being exposed to have these messages from the social media platforms, internet, etc., etc. And this is replicable everywhere. And what we have seen, we did another revision of all the Facebook as part of the social media platforms, and you can see that only 21% of these have a qualified knowledge. So we need to take actions, and that's actually what we do. And in Egypt, like every place, they have a specific points, have a change of the demographics, a change of the population more into the social media. So you need to have short message, and you need to educate them. And that's what actually we've done. And we started patient advocate groups in our park with 11 breast cancer survivors, 2 caregivers, 5 clinical pharmacists, and 2 nurses, giving them the knowledge that they need to have to become advocates. And since March 2023, we have a mandatory 3-hour session for every patient who will start any cancer-related therapy, whether surgery, whether systemic therapy or radiotherapy. And this is very important, and that has been shown as well that that more than 90% of the patients have higher satisfactions, and as well, this is a continuous program that have showed a prevalence. And that's also have been coupled that in the last months, we have published it of the 3 hours as a blueprint for other low middle income countries at the GCO Global Oncology. So basically, 327, a sample size, we have it from patients and caregivers. And what was seen that this low-cost 3-hour class improved the knowledge for patients and it have increased their applicability to better health life. We did so through public-private partnership and through working with the multi-sectorial. And that's the message here. And it's very important to take all this and to see how to scale it up from center to the country region. And I guess the PCCQI gives this impact, having the 4 dimensions. We need to prioritize a small set of early quick win indicators, the percentage of staging at diagnosis, the time to complete diagnosis, time to treatment, treatment completion, the registry coverage, and to take centers of excellence as pilots and to have this to document it. And it's very important to document. But then to have the embedded BCCQ indicators into the whole national breast cancer presidential initiative dashboards is very important. Learning and exporting is also very important. That's what we do, that we can share experience different to similar low middle income countries that we have in the regions. Because finally, my take home message that BCCQI gives a common language and a compass. It translates the broad GBCI goals into concrete measurable targets. And Egypt is not starting with zero, and I guess that there is more countries not starting from zero as well. And scaling is about alignment, not perfection. We need to start with a small set of high impact indicators, and we need to build upon. And by this, I thank you, everyone, for your time and listening.
Thank you so much, Professor Shash. This is an extraordinary demonstration that a country or a health system can improve things with a proper strategy. And I think that perhaps one of the most significant things in your presentation is related with political will. So I think that I understand that your country has a presidential initiative on women's health. So I think that that type of initiatives at the highest level can really change the things and improve the actions that otherwise are very difficult to implement, no?
Yeah, that's correct.
Well, thank you so much. And now we will move to the last presentation. One of the big questions in cancer control, and of course, breast cancer is part of this equation, is if cancer is a problem of doctors, if cancer is a problem of health systems, if cancer is a problem of the population. The first answer is one, that cancer is a problem of everybody, but in addition to this, and that is easy to say but difficult to implement, is that many stakeholders frequently are excluded from the conversation. So it is important for us to clearly understand that different structures of our society, of our healthcare systems, our country's political structure, our economies, is that everybody has a role in order to improve the situation. If not, it will be very difficult only for doctors to change the current picture. In this regard, I'm working with Policy Wisdom. It was a fantastic experience for us because when you have professional support in the development of technical things, it can be an index, but can be a policy, can be a document. You need professional experts working in order to transform the medical concepts in tangible document actions or formats that are applicable to the current context. So now we have the pleasure to have Ana Rita Gonzalez, the president of CEO and CEO of Policy Wisdom. She's a fantastic expert in this type of work, and she was extraordinarily supportive in order to have a final document that, of course, was contributed by the authors, but it was in great way supported by her expertise and her team's capabilities. Ana Rita, please, you have the floor.
Thank you, Dr. Kasab, and thank you, Dr. Shash and Ben, for fantastic presentations and for setting the stage for me to make this much easier. So, as Dr. Kasab says, one of the key elements of advancing any subject is the involvement of all stakeholders, the demonstration that an issue is an important issue, it's a relevant issue, is an urgent issue. In the case of breast cancer, it's even more important. Ilaria, the next slide. Because if, as Dr. Anderson was presenting and explaining, our job started, there has been a lot of progress, but the job is not done. We are faced with majority of the countries in the world not able to accomplish the desired reduction in cancer mortality by 2.5%. And those that are on track are only the high-income countries. In addition to that, all of the fantastic work done prior to the BCCQI have advanced the process but had not delivered on the impact we want to deliver. So we needed, as a group of experts, we felt that what we needed to do was to establish what was that framework, that tool that will bring together and coalesce all the previous efforts in a way that countries could see what was essential, what we needed to do to move the needle, to make changes. So that's why, as my colleagues had said, the BCCQI is intended to transform in a systematic way healthcare and to transform systematically anything you need policy. Because policy is that tool that allows for change to be broad and to be sustainable. So in developing the BCCQI, we made sure that it was standardized yet adaptable, because every country needed to see themselves in the BCCQI and how to implement it. We wanted it to be dynamic and evolving because we wanted countries to use it as they move forward, that they come back to the BCCQI to see what is next, what are the next steps I need to do. Of course, focus on practical implementation, align with global targets, and operationalizing everything that has been done before. Because we, as Dr. Kasab said, we wanted to make sure that at the end of the day, individuals and society are benefiting from the impact that we can generate by improving breast cancer care. Next one, Ila. So it is important to understand that opposed to pure science, when we're talking about policy, us policy nerds follow a policy cycle that starts with formulating policies based on what the challenges, the barriers, the gaps are, adopting those policies, making sure that those policies are adopted by countries and adapted by countries, implementing the policies and evaluating the policies. This is very important because the BCCQI is now at a stage that we need to implement, but we also need to make sure that we gather the evidence, the information that will allow us to validate every indicator, every word we put in that BCCQI to make sure that we continue progress. There's nothing wrong in science to improve things, The wrong thing is saying, no, this is perfect, we're not changing it. So in the cycle of policy making, we start with this formulation of the policy, making sure that we generate the need for that policy, that people understand why, that policy is enacted at being enacted, then it is adopted. So it's not enough to signing a policy or putting it on the books, but really applying it and using it. And then as the implementation goes, then the evaluation and the validation is essential. So we all have to make sure when we support the BCCQI that part of supporting the BCCQI is gathering the data and the evidence to make it even better in the future and to demonstrate the value of using it. Next slide. So what's next for the BCCQI? Our recommendation is that countries seek to implement the BCCQI using 5 basic steps. The first step is to conduct a landscape assessment. And that landscape assessment is for us to understand our current situation, because that will be our starting point, and the accomplishment through the applying the BCCQI would be our North Star. So once we do the landscape assessment, the second step is to prepare a SWOT analysis to make sure that we understand of within our current landscape, which are the strengths and the weaknesses we face, the opportunities we can take advantage of, and the threats that will impede the progress of implementing the BCCQI and having quality care for breast cancer. Once we do the SWOT, then we go into this process of identifying critical activities. One thing I've learned after 41 years of working on policy making is that we need to give policymakers details. We need to help them understand what they need to do. What is the next step? We cannot talk about things that will happen in 10 years from now, 5 years from now, even 2 or 3 years from now. Let's talk to them about what are the critical activities, what is the feasibility of doing them, why the urgency, why the relevance, so that we can really help them make changes. And we also need to celebrate the changes they have made and build on those changes and impact that they have made. Once we have defined these critical activities, then we need to consolidate priorities. As Ben explained, we have these domains, these dimensions, and we need to prioritize within dimensions what we need to do. We need to prioritize if we're going and start in a national way, if we're starting in a provincial or state level way. So we need to consolidate the approach of how we are going to take these critical activities and prioritize them. And then after we do that, then we need to create a roadmap. Roadmaps, as Dr. Shash demonstrated, are super important because they are the ones that give us the map that allow us to move from where we are to where we want to be. The map that allow us to bridge the gaps. So these are the 5 steps that we recommend that countries do to ensure and to start implementation of the BCCQI. We have some tips. The first tip is to ensure that we leverage the BCCQI to remind policymakers and other stakeholders, especially those that are not on a daily basis involved in health, but have a decision to make to be involved to what we do in health. Presidents, prime ministers, legislative bodies, the urgency and the need to support the ability to provide quality care for breast cancer. And as Dr. Shah says, the importance of demonstrating that there is good ROI when do this. So it's important to drive the urgency, as I said before, to make sure that we collect the data to demonstrate the impact, and also that we need more investment. As we all know, health systems are underfunded. And we need to demonstrate the value of the investment in breast cancer to make sure that things change and we're able to implement the policies. It's important also to generate national committees that will be working on the BCCQI. This is important because you always have a group. It could be a volunteer group, it could be a group by the Ministry of Health or by specialists. But the important thing is that you bring to that national committee all stakeholders are all individuals and organizations that have a say and an impact on implementing the BCCQI so that you can move the needle and that you ensure that if there are barriers, that you together find ways of moving from those barriers ahead. Important that you bring the financial stakeholders. We tend to criticize the financial stakeholders because they don't give us the resources, but we also need to be insightful and say, are we including them? Are we speaking their language? And as Dr. Shah presented, are we talking about the ROI? Are we explaining how this strengthens our health system? So it's important to include them. And the last thing is, another tip is consider creating a national network of BCCQI reference centers. So places where you have experts that understand the BCCQI, places where there are progress being made, implementations in progress, so that we learn from each other and we don't feel compelled, as we say in Puerto Rico, to regenerate warm water every single time, but that we use what we learn from. Next one, Ila. So as the title of my presentation says, there is a role for everybody with the BCCQI. We need to catalyze action of the diverse stakeholders and make sure that we all have clear roles so we can promote the BCCQI and we can together be accountable for implementing it and eventually for the success that it should create. So for policymakers, it's important that they make and build the investment case because they are the one trusted by the legislative bodies that need to assign the resources and the investment necessary. Also to create context-specific pathways because adoption will not happen unless the workers and the people in charge of the adoption understand what they are being asked to do. Cross-sector collaboration. We tend to exclude different sectors. Let it be the patient voice, or let it be the healthcare providers, or the private sector. And when the policymakers create the table in which we all can have a conversation, our experience is that the results are better and are faster because everybody has skills and have ways of supporting the process that if we work together, it's more important. But some people are afraid of including all of these voices. So it's the role of policymakers to create an environment in which we all can come together and work together. And of course, drive the demand for implementation. So push the implementers within the health system, push the funders, push the legislative bodies to really implement the BCCQI and explain why this will be good for the economy, for society, for individuals, and for the health system. The international community has also an important role to play. As Ben presented, so much has been done. And now with the addition of the BCCQI, we can drive renewed action by member state and by international organizations. We can strengthen global coordination to make sure we use resources and what we learn in the most effective way. We can use international community to find a way of having multi-sectoral cooperation. So work with the policymakers, work with the different sectors to ensure that that need for working together exists. And of course, those international organizations, let it be global or regional, that work directly with member states, they can help them in the process of implementation. It could be by helping them develop the roadmaps, by helping them develop the SWOTs or the assessment, but helping them find ways of doing the steps that they need to do to implement. And the multi-sectoral stakeholders are essential. And in the same way that when we pull the experts together, we made sure that we had multi-sectoral stakeholders that were experts in their own spaces so that we benefit from all of their knowledge. It is important that in implementing we do the same. Why? Because they will be the ones creating the advocacy that is needed because they are the ones that can help with education. I think the email went back one back. Okay, the education, help with the capacity building. Not every country has all the skills that are needed, the volume of resources that are needed. So the different sectors can help us with capacity building, with advocacy, with education, with evidence generation that, as I mentioned, is super important to continue evolving the policy and the BCCQI, and to engage those financial actors by giving them a rationale for the investment. But as Dr. Kassab and Ben and Dr. Shash said, it's important also that different stakeholders can help connect this to other development initiatives, health initiatives, global initiatives, and make it stronger. So the fact that there is an initiative on women health in Egypt creates conditions that make it easier to improve breast cancer care. So that sort of connection is super important. And then in the last slide, I want to leave you with a thought. The BCCQI really, I think we all see as bridging the gap to advance cancer care for all. We see it as a practical bridge that will go between global targets to national action. As I said, it is flexible. It's supposed to be owned by the countries. It is designed to have real world applicability and to be used with other policies that are very important in the countries. Policies like the national cancer plans, but also policies like the non-communicable disease agendas. And because we talk about bridges, I thought we need a visual that is a bridge. It looks a little bit like the Golden Gate. So it could be our pink gate, but it also can be our breast cancer bridge. So basically, when we think about bridges, and I'm going to study bridges for this presentation. Everywhere in the world, bridges are what connect you with another place you want to be. It's what connects you when there's difficulty getting from one place to another. The bridge makes that connection easier. So I hope we all get in this bridge and the BCCQI bridge, and we move from to really make a difference into women's life, into society's life, into the transformation of the health system. So breast cancer leads the way. So I am ready to go with all of you in this pink bridge to a better future. Thank you so much.
Thank you very much, Ana Rita, for this fantastic presentation. I took a photo of the bridge. I like the idea of the bridge because I think that it combines a process, because this is a process, a multi-sectorial participation, of course, policy, and I was thinking during your conversation about including the index in national cancer plans, because usually national cancer plans are plans and definition, but in general without including metrics. In general, I am speaking. And also to build investment case country by country, because we all know that the systems are basically country-based. So we have, 1 hour and 90 minutes. So I would like to ask you, each one of you, a last comment after we have a round vision of the index, in the context of global things, the example of Egypt and the role of policy. Ben, a final comment.
Well, I really want to congratulate my colleagues on those outstanding presentations. Dr. Shash, what has been happening in Egypt is a brilliant example of the rubber hitting the road, of actually making these connections. And I guess the one point I would make, Eduardo, because cancer has complexities to it, we need to think through the systems in advance of changes that we're going to make. The point you made about political will driven by advocacy and the changes that need to be in place, we have to be ready so that when a country or region recognizes this is something we want to work on, we need to be able to provide that. Here's where to start, because it becomes overwhelming if one tries to address everything at once. The great strength of BCCQI is that it segregates these different pieces into manageable components, whether it be early detection, prompt diagnosis, or treatment to completion. And so I think that very well summarized here is steps to go forward. I'm really excited to see how this all evolves over the coming months and years as we go forward. Thanks for the question.
Thank you, Ben. Dr. Shash, please, your vision.
Well, really, it's a pleasure to see the dream coming to reality. So this is something that I, for the past 20 years in practice, have been observing, that it's not only about prescribing the medication, it's about when the time to come from the start of the journey to the part of prescribing. It's not one size that fits all, and people need to know this. And clearly, what we have been inspired by Dr. Ben Anderson and the group from the Global Breast Cancer Initiative, and from all the work done by you, Dr. Kazab, that really you need to think of what you are being able to do at your own setting, because the setting in, for example, in South America is different from the setting in Africa. It's different from Egypt, then it's different from the sub-Saharan Africa. And what you don't accomplish is that you need to start and you need to move forward to try to do at least the basic analysis of what you have in place. And as you mentioned, the political will is very important. Without policy, none of these have been accomplished. And it's the policy and the political will of the Egyptian government to really do a shift in the breast cancer landscape. And it's a program. It's not only to focus in screening, because we did a lot of initiatives in screening mammography, but we really didn't reach to something. But it's really to have a stepwise approach. And this stepwise approach is really fitting for the low middle income. We did it our way. But again, with the BCCQI, it's a checklist that you will be able to see how you will do in the upcoming 6 months, in the upcoming 6 years, how to reach your goals, the KPIs, because this is what you always like to have in place. So I really thank you. We are been all inspired by the work done by Professor Ben Anderson and you, Professor Kazab. And really, it was a pleasure to be on this magnificent panel. And we are always there to help. So if it works for Egypt, it can work for every other place because, again, it's a low middle income country, but we need to make the change.
Absolutely. Thank you very much. And Rita, you have the final words.
That's good. Um, I am a big fan of health literacy because I think that part of the problem that we have is that sometimes we go into our little silos and we don't explain things in a way that people get them, that people feel a part of them. I want to thank both Ben and Dr. Shash for amazing presentations that were so health literate. Everyone that could have heard that, let it be someone on TV listening to CNN, or would have understood what you were saying. You made the effort to bring something that could sound very difficult or complex and explain it in a way that everyone can understand and want to be a part of it. So I hope we continue doing that, and we do that especially for policymakers. I always say that policy is the good part of politics. No one likes politics. Everybody says, oh, politics, corruption and this and that. But policy is the good part of politics. So let's make sure that we provide health literate information, that we recognize and celebrate politicians when they do the right thing, even if it's small, when they are moving the needle in the right direction. Let's make sure that when we talk down about politics, we don't talk down about the good policies that are in place or that are planned to be in place to make sure that life is better. And I think breast cancer is the perfect issue to do this because it affects half of the population of the world, but it truly affects the whole population of the world because these are the women that have children, that have husbands, that have parents, that have friends. So we affect everyone when breast cancer is there. So I'm so grateful, Dr. Kassab, for doing this session, for inviting us. And I'm humbled and honored to be presenting with Ben and Dr. Shash. So thank you so much, and let's move forward.
Thank you very much. So we coming to a close. This is a road. We are moving. We'll move forward. And thank you all. It is very good to have friends to go together following a common objective. Thank you very much and take care. Bye-bye.
Bye.
Bye-bye.
Okay.